Hello, my dear audience. This short video on idiopathic thrombocytopenic purpura, also known as immune thrombocytopenic purpura. It can affect in children and adult patient. In children group of patient, it is usually preceded by viral infection, and it usually resolve spontaneously. But in adult patient, it usually develop into chronicity, and it is usually not due to viral infection. Rather, it is secondary to other cause in case of adult patient. Other cause like connective tissue disease may be SLE. It may be secondary to infection like HIV, hepatitis C virus infection, and H. pylori or helicobacter pylori infection. It may be associated with or secondary to B cell lymphoma like lymphoma or plasmacytoma or multiple myeloma. It may be associated with pregnancy and some drugs. On clinical basis, spontaneous bleeding occurs when platelet count goes below 20,000, and patient may present as easy bruising, epistaxis, or heavy menstrual bleeding. Patient may have previous viral infection, and ITP features ITP has been found in COVID-19 vaccine infection. Patient may have features of connective tissue disease like SLE, and patient may have life-threatening bleeding. The question is, what are the life features of life-threatening bleeding? The number one, retinal hemorrhage on fundoscopy, and the wet purpura. Wet purpura means bloody blister in the oral mucosa. Bloody blister in the oral mucosa. Now the question, how to investigate this patient? CBC with PVF. CBC will show low platelet count, and the PVF will show the platelet are larger in size, and there may be microcytic hyperchromic anemia in PVF due to long-term bleeding, that is iron deficiency anemia. It may be found or not. The next investigation, the most important, that is bone marrow study, bone marrow aspiration biopsy with a study that will show hyperplastic bone marrow with increased count of megakaryocyte, that is the precursor of platelet, and there may be features of associated secondary associated disease like B cell malignancy, maybe multiple myeloma, or so on. Features to investigate the connective tissue disease like SLE, ANA, or anti-dsDNA can be done, and testing, appropriate testing for HIV, anti-HCV, and testing for H. pylori. Comb test, most important one. If patient has autoimmune hemolytic anemia as well as ITP. That means the combination of autoimmune hemolytic anemia and idiopathic thrombocytic purpura, then this condition is called Evans syndrome. Evans syndrome. Okay. And for the evaluation of Evans syndrome, direct Coombs test will be positive, and serum protein electrophoresis can be done if there is B cell malignancy. That will show monoclonal gammopathy. Okay. So this is the list of investigation for ITP. Now the management. Usually patient having platelet count more than 30,000, usually patient has no bleeding, and for that why patient needs no treatment. No need to treat the patient having a platelet count more than 30,000. But when patient present with spontaneous bleeding, usually less than 20 kilo platelet count, the patient should be treated in hospital. That means the patient needs hospital admission. And with this patient, treatment can be divided into first line and second line. For the first line, the most important treatment what usually given, that is a high dose glucocorticoid. It can be with prednisolone or dexamethasone. If you go with prednisolone, then the dose will be 1 mg per kg body weight per day, and if you go with dexamethasone, that will be 40 mg per day for 4 days. This is the high dose glucocorticoid. This is the first line drug, and if it is not sufficient for the resolution of the attack, then IVIG, intravenous immunoglobulin G, it can block the autoantibody that is formed against the platelet 2b3a receptor, glycoprotein receptor actually. So antibody actually in ITP, the antibody formed against the glycoprotein 2b3a receptor. So if IVIG given, that will block this receptor and thereby prevent the action of autoimmune acting on this receptor. So this is the second option under first line treatment modality. And if needed, platelet transfusion in case of severe bleeding, platelet transfusion can be given. But if the patient has two relapse, or primary refractory disease, that means from the very early beginning, patient is not responding to the first line treatment, that is the high dose steroid, IVIG or platelet transfusion. This all modality of first line treatment has been failed. That is called primary refractory disease. So if patients present as the primary refractory disease or patient has 2 or more relapse, then we will go for second line treatment. And these are the modality under second line treatment. The first one is TPORA, that means the thrombopoietin receptor agonist. The most important one is L-thrombopag. This is given orally. And romiplostim, this is parenterally. This is given parenterally. L-thrombopag usually given as oral route. Number 1. Number 2, splenic TKI, tyrosine kinase inhibitor, fostamatinib. This is the splenic tyrosine kinase inhibitor. If needed, splenectomy can be undertaken, and splenectomy is very much effective as it can lead to complete resolution or remission of the disease in 70% case, as well as another 20 to 25% case improvement of the condition. Mind it, splenectomy is very much effective management protocol in second line treatment for ITP, as it can lead 70% complete resolution and another 20 to 25% improvement of the patient's clinical condition. Immunosuppressive therapy can be used, among which the rituximab, but rituximab is the most important one. Mycophenolate mofetil, cyclosporine and tacrolimus are other options for immunosuppressive therapy. So these are the second line option of management. Now the last but not the least question you will be asked in your exam, that is the question: in case of relapse, what could be the cause of relapse? In maximum case, cause of the relapse are not known, but sometimes accessory spleen is a rare cause of relapse. Splenectomy done, but patient is in a relapse, that might be due to accessory spleen. Accessory spleen may be more than one. So this is all about. And the last not the least is before splenectomy, patient has to go through vaccination against encapsulated microorganism, that is bacteria, Haemophilus influenzae, Neisseria meningitidis, and Staphylococcus pneumoniae. So this is all about ITP from my side. Thank you very much.